Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about external rhinoplasty or open rhinoplasty. Previously, I have discussed in details about the steps that you need to do in a case of closed rhinoplasty. Today, there'll be a lot of repeat of the steps, but there are certain differences between the two approaches. We'll talk a little bit about that today. So, we'll talk about what is external rhinoplasty, what are some indications, what anesthesia and what is the procedure, and lastly, we'll end with advantages and disadvantages of external rhinoplasty. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, what is open rhinoplasty? So, open rhinoplasty, which is also known as external rhinoplasty, this is basically an approach to rhinoplasty. We can either approach rhinoplasty from the external aspect or from the internal aspect. Now, internal aspect is when you have given all incisions within the nostril itself. That is known as closed rhinoplasty. Here, you do not end up having a scar. But in open rhinoplasty, what is happening is we are exposing the nasal skeleton through a transcolumnar incision, which we combine with bilateral marginal incisions. Now, as a result of this gives us a direct visualization of the osteocartilaginous framework of the nose, which is why the visualization and the surgical access is much more in external rhinoplasty compared to closed rhinoplasty. Now, the external rhinoplasty is actually based on Rethy's technique. Next, let's talk about a few indications of external rhinoplasty. So, this is usually done in major deformities of the nose, like if there is a big dorsal hump. In that case, closed rhinoplasty is not a good approach to doing this. Then extends a saddle deformity or a very wide nose, a very marked nasal tip deformity, including significant rotation and projection issues. If there is very minor nasal tip deformities, even a closed approach is enough to do it. But if there's a marked nasal deformity, there's a lot of manipulation required. In that case, external rhinoplasty is the way to go. Then we have cleft lip nasal deformity, nasal deformities with benign tumors, repair of very big septal perforations, significant septal deviations, especially where you have high dorsal deviations, cases of severe nasal trauma, revision cases. This is another very important one. When you do revision cases, you will come across a lot of post-operative scarring and fibrosis. So there will be a lot of scar tissue there. So it'll be difficult to do revision cases in a closed approach where your visualization is not very direct. You do not get enough exposure and surgical access. Then, lastly, situations where assessment of the exact underlying pathology is very difficult. So, these are some indications of external rhinoplasty. Next, let's talk about what kind of anesthesia we would be using over here. So, now external rhinoplasty we can do both under local as well as general anesthesia. In general anesthesia, we usually try to do for extremely anxious patients. And in general anesthesia, we will prefer to use the hypotensive anesthesia. So, when you maintain the systolic BP and lower it down to 70 to 80 mm of mercury, then we are able to expect that there will be minimum or no bleeding during the time of surgery. So, if you are indeed taking up the patient on general anesthesia, then hypotensive anesthesia would be ideal in this scenario. Next, let's talk a little bit about local anesthesia. So, local anesthesia is actually quite safe and bleeding is also less. The advantages of using local anesthesia is that, first of all, because you're using adrenaline along with your lignocaine, it'll permit a very dry field because adrenaline is a very potent vasoconstrictor. Next, you'll end up saving the anesthesia cost as well as the manpower. And third, there will be less post-operative discomfort compared to a case of general anesthesia. Now, if you're doing local anesthesia, we need to give certain pre-medications before we have taken the patient up for surgery. What do we do usually? We use a combination of 30 mg of Fortwin and 25 mg of Phenargan given intramuscularly, and we usually give this 1 hour before surgery. Instead of Energen, you can even give 10 milligram of diazepam intramuscularly. Both are effective. Now, the purpose of giving these pre-medications is so that the patient is definitely going to be a little bit anxious about the surgery that they are going to undergo. So, these medications will help in relieving that anxiety and apprehension in the patient. And if your patient is an extremely anxious patient, in that case, even continuous sedation by giving IV midazolam through a saline drip is also an option that you can consider. Next, whether you do local anesthesia or general anesthesia, we have to give infiltration in certain parts of the external nose so that we reduce the chances of bleeding. Now, how are we going to do this? So, we are going to anesthetize the external nose. We are going to infiltrate in the subcutaneous plane. What is the agent used here? The agent used here is 2% lignocaine added with 1 in 1000 epinephrine, so that we are able to produce a strength of 1 in 50,000 to 1 in 1 lakh. And this is what we generally use for infiltration. And after you have given infiltration, we'll wait for about 10 minutes to allow the adrenaline to have its vasoconstrictor effect. We need a maximum effect before we start the surgery. So you should not be giving the giving the infiltration and directly starting the surgery. Give a time delay of 10 to 15 minutes before you start the surgery. Next, let's talk about where are the points that we are going to infiltrate. So let's look at our image over here. This image over here, this is giving us a rough idea of what is the external nose nerve supply. So the first nerve that we are going to be blocking is the infraorbital nerve. So infraorbital nerve comes out through the infraorbital foramen. So we are going to block it by inserting the needle about 1 centimeter. This is the alar margin, about 1 centimeter lateral to the alar margin on a line which is below the level of the pupil. Now, this needle has to be angled superiorly so that you end up striking the bone just below the infraorbital margin. And you should be able to palpate this with the index finger of your left hand. And this is the infraorbital nerve. And there are certain nasal branches as well of the infraorbital nerve, which we can block by giving an infiltration inside the nasal cavity. So what are we going to do? We are going to pass the needle inside the nasal cavity in the lateral wall of the vestibule near the piriform crest, and we'll deposit some of the infiltration over there. So that this is our first nerve that we have blocked. Now, second is, this is our columella, right? So we are going to block the nerves that are supplying over here. So at the base of the columella, we'll give an infiltration by inserting the needle at the alar base, and we'll do it from the right side to the left side. And this will end up blocking some twigs that come from the palatine nerves. So this will be our next blockage. Our third blockage would be on the dorsum of the nose. Now, dorsum of the nose has multiple nerve supplies. If you can see, we have the external nasal nerve, which is a branch of the anterior ethmoidal nerve. To know more about the anatomy of the external nose, what is the nerve supply, you can check out my video where I've spoken about the surgical anatomy of nose in relation to rhinoplasty. So we have two nerves to block here. One is the external nasal nerve and one is the infratrochlear nerve. So we are going to pass the needle here between the upper and lower lateral cartilages through the nasal cavity. So we are going to go from the nasal cavity inwards, and we are going to insert the needle somewhere in between the upper lateral cartilage and the lower lateral cartilage. And at this point, we will keep the bevel towards the skin. And infratrochlear and the external nasal nerves are going to get infiltrated when we deposit the solution somewhere between the medial canthus of the eye and the nasion. So this will block the infratrochlear nerve somewhere over here. And second, at the level of the lower border of the nasal bones, somewhere here maybe, and that will block the external nasal nerve. So this is how we are going to infiltrate here. And lastly, If we are going to use a transfixian incision, we can even put some solution in the membranous part of the septum. So that's about the infiltration anesthesia that we are going to give. The main nerves that we are blocking here are the infraorbital nerve, the palatine nerve, external nasal nerve, and infratrochlear nerve. Next, let's move on to discussing what is going to be the position of our patient. So, we are going to place our patient in a supine position with their head end elevated to about 20 degrees. What is the reason we are elevating their head? When you end up elevating the head, especially in a case of a nasal surgery that you're doing, what it does is it causes a slight postural hypotension, and therefore the bleeding reduces during the time of surgery. Next, when you have positioned the patient, the second important thing is the lighting in your OT. So we need to be using two lights. So if this is our patient lying over here, this is their head end and this is their foot end. So one light has to focus on the face and the nose from the top. So this will be our first light. And the second light has to project somewhere from the foot end of the patient, and this should be projecting towards the inside of the nose from the foot end of the patient. So the lighting has to be adequate when you are performing a rhinoplasty. So now that the lighting is adequate, the next step would be to dress and drape the patient. So we'll perform some cleaning of the patient's the area of the that we are going to operate on with some kind of antiseptic solution. You can be using betadine, for example. Next, we'll be doing draping. So towels will be draped such that the forehead and the entire face remains exposed, and the lips are covered with wet gauze to prevent dryness. And before you start giving your opening incision to start the procedure, we are going to pack the nasal cavity with ribbon gauges which are soaked with 4% lignocaine to supplement with some topical anesthesia so that there is no blood coming out when you start giving the incisions. So this is about all the preparation that we do before we get started with our procedure. Starting off with our procedure. So, first of all, we will be giving some incisions. Now, here is where our approach is going to be very different from performing a closed rhinoplasty. So, the incisions that is commonly given here is two incisions. One is we have marginal incisions. So, these incisions that on the sides that you are seeing, these are the marginal incisions. And the second incision that we are giving is the transcolumnar incision. So marginal incision are the incisions that we are giving along the caudal border of the lateral crura of lower lateral cartilages. Now, if you want to read more about the incisions and understand what are these incisions in rhinoplasty, what are the different types that we can use, I have a separate video on rhinoplasty incisions. You can check it out over there. So here, marginal incision is made along the caudal border of the lateral crura of the lower lateral cartilage, and this incision is then carried medially and inferiorly along the cephalic border of the medial crus up to the lower part, and then we extend the incision with a right angle turn to the caudal margin of the medial crus. Then the next incision that we have over here is a transcolumnar incision. So transcolumnar incision is an incision that we are just giving in the middle of the columella. If you look at the images over here, we have multiple different types of transcolumnar incisions that we can use. Like we have the inverted V, we have the W, staircase, low columella, gull wing, mid columella. There are different varieties that are used. So this incision that we are giving in the columella, we are going to join this incision with the medial arms of the marginal incisions that we have already given. And this incision should be situated in the upper 2/3 of the columella, normally at the narrowest point. And why is that? Because we want to ensure that the medial crural foot plates are able to give adequate support. So we do not end up having a depressed scar when we stitch up the incision. So ideal place to be given is in the upper 2/3 of the columella. In the lower 1/3 of the columella, what happens is the medial crura bend backwards towards their attachment to the caudal septal area. So in this area, the skin of columella is actually quite unsupported. That's why we will avoid the usage of a low columellar incision. We will prefer to use it in the upper 2/3 of the columella. So now that we have given our opening incisions, our next step is to dissect the soft tissue envelope. Now here, what we are going to do first is we will elevate the dorsal skin from the lower lateral cartilages. So we will have to perform some dissection over here. So using a fine skin hook and a fine scissor, we'll dissect off the skin from the columella first, and then we'll continue the dissection from the columella to the dorsum upwards. And we have to be very careful that we do not end up cutting off any cartilage over here. And the second thing we have to be careful while dissecting here is you can come across arteries over here. Near the transcolumella incision, we find two small columella arteries immediately below the incision that you are giving. And this may require some cauterization to control the bleeding. Now, elevation over the lateral crura is way more easier because in this region, it is quite loosely attached. So we continue the elevation of as you can see, elevation of the soft tissue envelope over the lower lateral cartilages. Now, as we go upward, we have to identify the ligament of the nasal tip that you can see in this image. So ligament of the nasal tip has to be identified first and approached. So, and we divide it by dividing it very close to the skin, and we remove it together with fibrous tissue in between the domes of the lower lateral cartilage. Then the skeletonization of the nose will continue to do that, and will continue to extend it right up to the nasofrontal angle of the nose. We will be dissecting very close to the perichondrium and periosteum, and to learn about the lateral extent of the dissection, we have to be careful only to extend it to as much as we need exposure to. Now, as you have dissected out the soft tissue envelope from the underlying cartilages, we are going to lift the skin off with the help of a retractor, and we'll fix it to the drapes with the help of a clamp. Now, while you have retracted to expose this dorsum, we have to avoid folding the columellar flap under the dorsal skin so that we do not end up causing any damage. So you can see in the image over here, the lower and the upper cartilages and part of the bony pyramid gets retracted. Now at the end, when you retract the whole nasal skin with the help of a retractor. So this is about dissection of the soft tissue envelope. We are going to start it at the level of columella and slowly go upwards towards the dorsum. We will only expose as much as we require, and we have to be careful that we do not end up causing any cuts to the cartilages. And another important step would be to identify the ligament of the nasal tip and dissect it very close, divide it very close to the skin. Next, after we have done this, our next step would be to perform any septal surgery. So in case this is a case of septorhinoplasty, we will perform the septal correction at this stage. So the medial crura of the lower lateral cartilages will be separated at this point so that we are able to expose the caudal border of the septal cartilage and the maxillary spine area. And you perform your septoplasty, and then after that we'll approximate back the medial crura with the help of sutures. Now there's a second approach over here to septoplasty where you can even approach it from the top after you have incised the upper lateral cartilages submucosally from the septal cartilage. So these are two approaches that we have to performing septal surgery while doing an external rhinoplasty. If you want to know more about the steps of septoplasty, I have a separate video on the procedure of septoplasty. You can check it out over there. Once you have performed septal surgery, our next step would be to perform a hump removal. And this we are able to do quite under visual control. So there can be a cartilaginous hump and a bony hump. So you'll excise first the cartilaginous hump with the help of a knife, and then we'll use the osteotome to resect out the bony part of the hump. If necessary, even the nasofrontal angle can be modified by excising the soft tissue and by sculpturing the bone with a chisel or osteotome. Next, after we have removed the hump, we are going to palpate the area and feel for any kind of irregularities. If there are any irregularities, we use a rasp to rasp the bone in that region. So rough edges are all rasped and we are done with this step. Next step would be to perform the osteotomy. Now, what do we do? Osteotomies are basically this bony cuts that we are giving to narrow the nose. We have three types of osteotomy over here. Now, again, osteotomy I have discussed much more in details in a separate video. You can check out it. I'm linking it above. We'll just shortly get through it. We have three types of osteotomy over here. If you look at the image, this is our lateral osteotomy. This is our medial osteotomy and this is a transverse osteotomy. The purpose of lateral osteotomy is that you're mobilizing the nasal bone over here so that you are able to move the nasal bone inwards. Medial osteotomy is where you're separating out the nasal bones from each other, and transverse osteotomy connects them, and this is ending up defining the upper limit of bone movement in your particular case. So, lateral and medial osteotomies are performed without fracture before you shift the bony walls towards the midline. Once all your osteotomy cuts have been given, we will shift the bony wall towards the midline and adjust according to how much you need in your patient. Sometimes the transverse osteotomy is not always required. Sometimes it can be required, and in that case, you do it. So now, after you have narrowed out the nose, uh, we will palpate the entire nose and see whether the surface is completely normal or not. If there is any kind of irregularities, we will take care of that. Another thing you need to be careful while giving osteotomy is that you should not be forcing the movement of any bone without giving the osteotomy cut properly, because that can end up actually causing a fracture of the bone areas of the bone in different places because of unintended force that you are pushing. After the osteotomies are done, next is we will do some tip remodeling. So this is done according to whatever preoperative planning you have done for your particular patient. We will place columnar struts in their exact position, and tip grafts if needed are accurately positioned, and we stitch it in situ. The domes has to be sutured to each other to achieve narrowing of the lobule, and medial crura are also sutured to each other if the septum has been approached to it. So once all the nose tip work has been done, next is to close the incisions. We are going to replace the skin flap and suture it back into position. We usually use absorbable sutures for the marginal incision and fine interrupted sutures for the columnar incision, usually 5-0 Prolene. So now we have closed down all the incisions. Our last stage would be to pack the nose. So now while we are packing the nose, there are different steps over here. So first, for packing the nose, if you have performed a septorhinoplasty, in that case, the depth at which we are going to pack the nose is going to be much deeper. Whereas if you have not done septoplasty, in that case, a very light packing just beyond the vestibule is enough. What are we going to be using? We are going to use Vaseline or paraffin lubricated ribbon gauze. And the purpose of packing over here that it will help you in reapproximating any unsutured incisions and even help you in preventing septal hematoma. We should be careful not to pack the nose very tightly because that may end up in splaying out all the bony fragments, bony segments that you have created by doing the osteotomy cuts. So we have to pack it very lightly, not tightly, so that it ends up displacing the bony segments that you have cut. So this packing later has to be removed 48 hours later if you have not performed any septal surgery. If in case you have performed septoplasty, in that case we remove it after 72 hours. Next is fixing the skin. What do we do here? I've already spoken about this in my previous class on closed rhinoplasty. Here, we will first clean up the skin, and any collection of blood under the skin is squeezed out with the help of a gauze piece. Now, what is the purpose of taping up the nose? The purpose is, first of all, it will help us in redraping the skin and fixing it effectively. Second, it will prevent any hematoma formation. Third, it will reduce any dead space if it is present. And fourth, it will prevent malpositioning and asymmetry of the reshaped cartilages. So here we are going to be using a tape of about half to 1 centimeter broad adhesive tape or even a micropore tape. So first we will put a longitudinal strip like this. We are going to apply it around the lobule at the upper part of the columella and extending to about halfway to the lateral nasal wall. And we are going to pinch it at the tip to splint up this narrowed region and hold the columella up. After this, we will apply several layers of tape on the dorsum of the nose like this, where we go from the supratip to the nasion, and these tapes should be overlapping each other. However, very important is that you should not do any wrinkling of the skin when you are doing this. Next step is to perform splint. Now, why do we apply a nasal splint at the end? There are particular reasons for it. First is it will help you in preventing swelling of the nose. Second is it will maintain the position of the bones that you have moved around. Third is when the patient is sleeping, it can cause accidental displacement of the bones that you have moved. So, to prevent that, we will put the external nasal splint. And fourth is it will also provide protection to the whole region from minor injuries. Now, what are the materials that were used here? The best material here is to use a plaster of Paris cast because this sets in position very effectively, and even when swelling occurs, the plaster cast does not lift off easily. There are other materials like dental composition material. This can also be used because it sets easily, but the disadvantage is that during summer, when there's too much heat, this can actually soften up and lift off because of soft tissue swelling. Third, we can even use aluminium foil splints. However, the material of choice over here is a plaster of Paris cast. So what we use here is a 6-layered plaster of Paris bandage. We will soak it in tepid water and then we'll apply it on the nose till it becomes hard and adequately set. Now, you will fix the tip with separate pieces of plaster bandage, and this plaster splint that we have is fixed with zinc oxide or micropore adhesive tapes. Sometimes you may or may not even need forehead extension of this splint. Now, important to know how far will you apply the splint. The lateral extent of the splint is very important. The splint should not extend lateral to the lateral osteotomy sites over to up the normal face, because if that happens, if it extends right up to the face, what will happen is any movement of the face that you do, maybe you're smiling or laughing or chewing or talking or any emotional expressions you're giving, all the movements of the face will be transmitted through the splint to the nose. So therefore you have to limit the splint on the lateral extent. Now, this splint that you have applied, this has to be removed somewhere between 7 to 10 days depending on how your patient is doing. If you have seen that there's marked postoperative swelling, in that case, the splint is coming loose. When the swelling goes down, you have to reapply the splint with another new one so that it fits properly into your patient's case. So that finishes the procedure of external rhinoplasty. Next, lastly, we'll talk about a little bit about the advantages and disadvantages and end the class. So coming to the advantages, the advantage of this is that the deformities can be diagnosed much more accurately. And that's because you have excellent exposure and direct visualization of the whole nasal anatomy. You're able to see everything directly. So because you're able to see everything directly, it is much easier to give a accurate assessment of asymmetries. And because again you're doing under direct visualization, the advantage is that you get more precise placement and fixation of the grafts. Next, the nasal septum can be approached from two portions over here. As I mentioned, there are two approaches. One, you can approach from above downwards, or second, you can approach through the caudal border. So we get two approaches to septoplasty in this case. This is also advantageous in difficult cases and revision cases, and this is very teaching friendly. So this is ideal for demonstrating to your students and training them. Lastly, it also gives you a better assessment of the nasal tip. Next, talking about the disadvantages, there can be an external scar. Even though it's a very tiny incision, and if you approximate the transcolumnar incision properly, it can leave out a tiny scar that may not be likable by the patient. And in external rhinoplasty, we have more manipulation of the soft tissues happening. So we have more chances of post-operative edema, especially at the tip region, a longer recovery time of the patient, a longer operating time. And this is a technically more challenging thing to learn. And there's another problem here because we are giving a columellar incision and approaching from there, the patient can experience some temporary columellar numbness in the postoperative period. So that's all about this. If you have any doubts regarding this, please note them down in the comment section and I'll get back to you. Thank you.